Okay, hi everyone. Thanks for joining. So my name's Tom. I'm a fifth year medical student at Oxford. And today I've been asked to talk about medically unexplained symptoms. So what I'm going to cover is what exactly MUS is, what it means, some examples, the nosology, which means the terminology and the different ways that it's referred to and how that's evolved over time. And then the contrast between how doctors typically view these patients versus how the patients themselves are describing their symptoms. I'll cover some theories as to what is actually going on, and really want to focus on how to assess and manage these patients, which are classically thought of as very, very difficult to get a good grasp of. Then I'll cover some specific syndromes that come under the MUS umbrella, namely functional neurological disorder, chronic fatigue syndrome, and inflammatory bowel syndrome. Okay, so what do we mean by MUS? Well, it's been defined here as a broad spectrum of physical symptoms that cannot or have not been sufficiently explained by organic causes after adequate physical examination and investigations. So this is a rather long sentence. Essentially, the point that the authors here are trying to make is that once you've ruled out the diseases that we know about and you're left with a patient who's still experiencing symptoms, then that might point you in the direction of so-called medically unexplained. So what are some of these symptoms? Well, this is a list produced by the Royal College of Psychiatrists, which is a great resource, by the way. They have really, really clear information written for patients to read, and often I find it's actually easier to understand it from that perspective. So they talk about muscle or joint pain, back pain, headaches, tiredness, feeling faint, chest pain, palpitations, GI disturbance, as well as that they're touching here on a couple of the different syndromes, so collapse and fits, weak paralysis, and other neurosymptoms might fit under the umbrella term of functional neurological disorder, which we'll come on to. So the point really to impress here is that MUS can present in all sorts of different ways, and these symptoms are very real, and we can't find an alternative explanation for them, but the person experiencing these symptoms is very much suffering. And between patients, it can be very, very variable, and also the symptoms can somewhat change over the course of someone's lifetime. So IBS, fibromyalgia, non-epileptic attack disorder, these are kind of named examples of diseases that fit under the MUS umbrella. And then you screen and other definitions: somatization disorder, health anxiety, hypochondriasis. Now, these are all terms that some of them are used, and some of them are somewhat outdated now. And I'll touch on to why this is important to think about in a moment. But really what I want to say about this is that the terminology used to describe MUS and related syndromes is very mixed and variable, and it's kind of muddled in the literature. And depending on which diagnostic criteria different people are using, you're going to see different things written. And the other thing to say is that MUS is extremely common. There's some numbers on the slide here, but I've read actually that it's been reported to vary between 25 and 75% of presentations to clinicians could be medically unexplained. This diagram, particularly on the left, I think is quite helpful because, as I've said, there's a few different terms that are kind of banded around, and it's quite difficult to understand how they all relate to each other. Particularly when you flip between review article to review article, and they keep changing the terminology, and sometimes people even change the terminology halfway through their own paragraph. So how can we understand this? So we have medically unexplained symptoms, which refers to, as I've said, the idea of illness without disease. You might have heard it referred to as. We can't find another cause. The patient is still suffering, and they've got these symptoms going on. Now, the kind of most updated terminology to describe a kind of subset of these presentations is somatic symptom disorder. And I'll show you the DSM-5 criteria on this in a moment. But you also hear about functional, which has a smaller as functional somatic syndromes, and examples of these might be IBS and fibromyalgia, for example, this kind of named sub-constellation of symptoms. So this is really just a diagram to show how all of these different terms relate to each other. And if you come across something in a lecture or any other sort of paper, then hopefully this diagram might make it a bit clearer. But this is really to say that MUS is the kind of overall term to describe these symptoms. And this is a little kind of pictorial representation of how technology, as I've said, has changed over time. So DSM is the American, but is really used very internationally, criteria for making a diagnosis of a condition in the kind of psychiatric sphere. And there's this idea that DSM-4 was updated to DSM-5 in about 2013. So this concept of somatization and somatoform disorder, these terms aren't used anymore. Well, they could be, but it would be outdated. The updated term is somatic symptom disorder, and this is a very specific diagnosis, and I'll show you the criteria in a moment. So if you hear somatization, somatoform disorder, really what people mean is this somatic symptom disorder, which, if I go back to this slide, you'll see as a kind of subset of MUS. Okay, so here it is. Here's the DSM-5 criteria for somatic symptom disorder. And the concept really here is that symptoms that the patient is experiencing is causing some kind of functional impairment in their daily life. There's this idea of thoughts about the symptoms relating to some sort of mood component and a preoccupation with thinking about symptoms. The final point says that although any one somatic symptom may not be continuously present, the state of being symptomatic is persistent. So there's this idea of it lasting more than 6 months. Okay, and here's just a summary of some of the points I've spoken about, but this is quite interesting. So the top paragraph here, there was a small study completed by Marks et al. In 2015, and essentially what they did is they sent a questionnaire to a group of people, and they said, okay, imagine a scenario where you have symptoms and they can't be explained by an alternative diagnosis, and doctors don't quite know what's wrong. So that is in essence MUS. And they said to these people, how would you want to be labeled? How would you want to be diagnosed and referred to? And actually, MUS as a term ranked third on this list, behind persistent physical symptoms and functional symptoms. So why am I telling you this? I'm telling you this because if you ever find yourself in the clinical environment and this terminology is being used as a diagnosis, then perhaps it might be more appropriate to actually refer to these symptoms as something else. And there's some suggestions of exactly what you could say on this slide. The other thing to note is actually that this questionnaire was completed by healthy individuals, and I think it would be really interesting to see how the questionnaire might be different in someone, a population of people actually diagnosed with MUS, because perhaps that might change even further. Then there's this idea that MUS and persistent physical symptoms might be the same thing, but they might not be the same thing. This is one of the other reasons that I put up that earlier kind of Venn diagram, just to show how all of these things are conflated and confounded in the literature and how they might relate to each other. And then the final point on this slide before we move on is basically to say that depending on what type of doctor you are and where you're encountering these people, well, you might diagnose a different thing. So maybe you haven't seen the DSM-5, you're still using the DSM-4, or maybe if you're a rheumatologist, you diagnose fibromyalgia, but if you're in general practice, you call it chronic fatigue syndrome, and maybe there's some sort of confusion over exactly what's going on. So I'll just summarize briefly what I've said so far. MUS is medically unexplained symptoms. That is, symptoms that have gone on for a persistent amount of time. They're causing a functional impairment in the patient. They're bothersome. They are causing some sort of anxiety and preoccupation, and they are very, very real, very valid, and very bothersome to the patient. But there's this idea that we haven't found an alternative diagnosis for them. The terminology is confused in the literature, and it seems to be different depending on where you look, but there's a summary diagram that hopefully will make it easier for you. So let's move on. Here are some quotations from a qualitative paper that a research group conducted, collating quotations from FY2 doctors and FY1 doctors. So the doctors in their first 2 years of work, and it's basically a collation of their opinions about medically unexplained symptoms. So I'll just put some of these quotes up now. So you can read the full paragraph, so you can just look at where I've highlighted in orange. But really, what I just want to show you is the kind of scale of the problem. Is this idea that we've got patients who are suffering, and we've got doctors who don't really know what to do about it. Some of them are saying, "I feel helpless. I don't know what to do. I'm just going to keep referring to other people." And some of them are saying, "I don't really want to deal with it. I want to deal with the sick people where I know how to help them." And the point that I impress upon you now is that attitude is unhelpful. And if you've been to any of the Oxford lectures in the Psychology for Medicine course, then they might have posed the question to you of, what is your job as a doctor? Is it to treat disease? Is it to treat illness? Or is it to treat suffering, or some combination of those things? And I would argue that it's to treat someone who is suffering. And illness is this subjective concept, and people with MUS have symptoms, and they are suffering. So this idea that we don't want to treat them because we don't know how to is actually unhelpful. And there are some strategies and some recognized approaches in this lecture that I hope will be helpful to you. So let's look at examples of how MUS might present. So here's one case. A 32-year-old with high blood pressure, tiredness and headaches. He's worried about work. On examination, you couldn't find anything to explain these symptoms, and you provide empathy, support, and reassurance. You withheld from tests and investigations. And actually, with that approach and with some painkillers, this patient was demonstrated to show an improvement. He could get back to work, and that was that. Case closed. So here is an example of someone with a constellation of symptoms that, if you looked at it as a doctor, you'd think, well, I'm not quite sure how to pin these things together. There's a few different things going on, and tests, I haven't done tests. Examination is normal, so I don't really know what to do. But explaining that I'm sorry you're experiencing these symptoms. It sounds really uncomfortable. I'm here to help you. I'm here to reassure you that actually I can't find anything worrying going on. Was enough and in itself therapeutic. Let's look at a different example. So a 44-year-old lady with lower back pain. She's got some comorbidities, diabetes, obesity. Pain is interfering with her life, and she's seen all sorts of doctors over the last year or so. Having difficulty sleeping, but didn't feel depressed. Physical exam revealed no neurologic deficits, but some kind of mild musculoskeletal problem. MRI spine didn't show why she had this pain and these symptoms. Implemented a program of treatment of MUS and depression. Now this is interesting, isn't it? Because earlier it said that she didn't feel depressed, and later on it said that they're treating her depression. I want you to keep that in your heads, because I'm going to come back onto this idea later on. And why have I put this case up? Well, it's because it's showing the idea that mood and sleep and MUS are all very related to each other. So mood and sleep have got this very clear bidirectional interaction that we know about. There's also this idea that MUS and low mood and anxiety are very, very comorbid. And I want to touch on that in a moment. So this is another example of how a patient could present. Here's one final example of how a patient could present. 50-year-old, long history of severe pain, headaches. He wants to shake things up. He wants to get better. He doesn't want to stay like this. He hasn't got depression, but he does have anhedonia, so lack of enjoyment, which, as you may know, is one of the 3 core symptoms of depression. But without the other 2, you can't make a clear diagnosis. He's got trouble sleeping. Physical exam didn't reveal a cause for his severe neck pain, and neither did MRI scans. And potentially this man showed some improvement after treating MUS and depression. Okay, so there were 3 cases here just to show you that the kind of key the common presenting features here are pain, suffering, and symptoms that you can't quite string together. And despite doing some investigations, in some cases, you don't know what's going on. So this would lead you to a diagnosis of MUS. So how can we understand MUS from a mechanistic level? Well, I've put a reference at the bottom of the following slides. And this paper did a systematic review on the type of evidence available. And it categorized the mechanisms of MUS into 9 categories. And I'm just going to run through these briefly. So as I went through, you can decide in your heads whether you think this is likely or not. And if you look in the paper, you'll find some primary references where you could these a little bit further. But for the sake of in a lot of detail, but I'm just kind of giving you a flavor of what we think might be going on. So, immune system sensitization theory. This is a bit of a strange one, in my personal opinion. It is the idea that cytokines are and actually there's this idea that the immune system at some point in the past has been sensitized, so it's made vulnerable, and then later on, when something's off, it can result in this feeling of okay. And then we have this concept next of endocrine dysregulation. So the HP axis, the hypothalamic pituitary adrenal axis, is the one involved in the body's stress response, and hypercortisolism, excuse me, is referring to the end product of this axis, cortisol, and basically just saying too much of it. And there's some idea that a dysfunction of this process is predisposing someone and developing some of the symptoms associated with MUS. Autonomic nervous system dysfunction. So this one possibly has some sketchy evidence, but there's an idea that somebody who undergoes a period of stress, physical or psychological, normally would recover from that. And you've got this kind of balance of sympathetic and parasympathetic nervous system that allows you to recover after this activity. In someone who's got MUS, possibly the parasympathetic nervous system isn't functioning normally, and so you have this increased stress burden, quote unquote. Fourth one of the 9, abnormal proprioception theory. So you've got a hyper-awareness of your body proprioception, which is your sense of joint position, for example, and you're misinterpreting this as pathological. So the authors of this paper use the example of muscle tension. You feel muscle tension, you misinterpret that as abnormal, and it causes you to think too much about it, and you develop a kind of cognitive process which leads you to experience medically unexplained symptoms ultimately. So those were some physical mechanisms, and now there's a couple of psychological. So somatosensory application theory. So this is very, very similar actually to what I've just said. And there's this idea of getting trapped in a vicious cycle of noticing what might be completely normal body sensations, but attributing an abnormal meaning to them. So you've noticed a twinge in your chest and you think, oh my goodness, I must be having a heart attack or something. And that sort of cognitive process leads you to focus more on the chest twinge, spasm, and you kind of get in a cycle where you notice it more, you pay more attention, you notice it more, and then you apply this abnormal meaning to those sensations, and you kind of spin into a bit of a state. Sensitivity theory, this is suggesting that some people are more vulnerable to develop MUS than others. So childhood experiences, adverse childhood experiences, parental influences, touch on both aspects a little bit more later on. Negative affect, so how you kind of present yourself and your mood to be, and catastrophic thinking, which is interpreting things as the worst possible outcome. All of these things can predispose someone to the US. Then the authors have combined a few different theories, a physical and psychological, to a kind of composite model. Sensitization theory, an enhanced response to sensations as a result of former experiences of these same sensations. So you felt, what example would this be? Yeah, you've had a sore throat and you've experienced that sore throat, and actually that time you needed your tonsils out, and that was a really traumatic experience. You notice some similar sensations to when you had your tonsillitis at a separate point in time, and you're then getting really worried that something else must be going on that's really, really wrong because you're experiencing those same symptoms again. Signal theory filter, this is, oh, beg your pardon, this is the idea that you've got all sorts of interoceptive information from the rest of the body going to the brain, and normally you ignore most of it, but for people with MUS, actually, there's this idea that subconsciously they can't distinguish between normal and pathological signals that are coming from the rest of their body. And then finally, illness behavioral theory. So this one is to chronic fatigues. They apologize for the gendered language that they used here, but it says, for example, when a patient with CFS believes she will get more tired by doing sports, she will stop all physical activity. This may more awareness and susceptibility of physical symptoms. So CFS is one of these kind of syndromes under the MUS umbrella. We'll talk about it more later. And the idea is you're incredibly tired, you're debilitating tiredness, and someone might choose to respond to that by resting because they're tired. But when they're spending more time thinking about their physical symptoms and tiredness, and actually you get into one of these kind of vicious cycle type situations. Now, finally, the authors speak about an integrative model, a cognitive behavioral theory model. Now, you may have heard of cognitive behavioral therapy, CBT, and this is the idea that there is a model that fits in with that to explain the way in which a patient might develop and get stuck in this loop of having medically unexplained symptoms. Important to say that when I say get stuck in, it's not a kind of voluntary conscious state that these people have entered into, and this model is trying to explain what's going on and try and break that cycle. So there's biological, psychological, and social factors, and each of these can predispose, precipitate, and perpetuate the development of medically unexplained symptoms. And this is an example of a psychological formulation. So a formulation is a way of understanding why someone has symptoms and then presenting targets to attack and undo the kind of disease process from that perspective. And there's this idea that doctor and patient together have to search for the personal circumstances that might contribute to the symptoms. So an example of biological factors, genetics, although it's alleged that there's actually quite weak evidence for that. Possibly the psychological and social, there's this idea of parental influences. So you've been brought up by parents who are very health focused, and they As soon as you have the slightest sore throat or cold, you're straight into the GP or straight into A&E. And there's this idea that if you grow up in that environment, you're more likely to display health-seeking behavior, and that might predispose you to MUS. Precipitating factors are things that bring something on. So an example of this in the social way might be a family member or a close friend has had a heart attack, and then you develop musculoskeletal chest pain, and you believe that this must be a heart attack, and you start selectively focusing and attending to those symptoms and catastrophizing in your head, and you get stuck in one of these vicious cycles. So really, this formulation is combining some of the different theories that were presented on the last few slides to explain how someone is triggered into developing MUS. And perpetuating are things that keep the cycle going. So the vicious cycle and the cognitive attribution of different symptoms is an example of perpetuating factors. Now, I've mentioned the last 2 points on this slide, but just to flesh out the first one, I spoke about it earlier, but this is just to show that mood and anxiety feeds into selective attention and vicious cycles. So if you have depression and anxiety as well as MUS, the vicious cycle is exacerbated. But there's also a bit of confusion about whether or not MUS and mood and anxiety disturbances are concomitant and comorbid, or whether they're actually causal. So maybe the low mood and anxiety is predisposing you to MUS, or maybe you have MUS and therefore your mood and anxiety goes up and mood goes down. And I'll show you some patient experiences of symptoms on the next slide, and hopefully then you'll be able to see how someone can enter into a low mood or an anxious state. Oops, sorry about the formatting here. So this is different, but a similar qualitative paper to when I showed you the foundation year doctors' opinions on MUS. This is from the patient perspective now. And there's this idea of panic. There's this idea of fear and being ashamed of symptoms. And there's an example here of some precipitating triggers and of a kind of vicious cycle. So hopefully the impression that I can give you here is of a constellation of symptoms in a population of people that is causing quite a significant impairment in mood and function, and really is very, very bothersome to these people. So you can understand how if you've got MUS, then and you've got this sense of panic and fear, it could send you into a spiral of developing low mood or anxiety. And of course, that's going to make things worse. So you'll get trapped in a vicious cycle of MUS and mood. But the kind of chicken and egg situation of these things are a little bit muddled. Okay, so far I've spoken about what MUS is, the kind of confusing nature of the terminology. I've given you some examples of how patients experience it versus how doctors kind of perceive these symptoms. And I've given you an overview of a couple of different theories to explain how and why MUS comes about. So now we're going to talk about what are we going to do about it. There's an absolutely fantastic review paper by Hussein et al. That was written a few years ago that is describing very clearly and with quotes and examples of how you could bring this up in the clinical environment of your approach to these patients. So they walk in the door and it becomes maybe obviously apparent, or maybe it's a little bit more nuanced that this could be a presentation of medically unexplained symptoms. Or maybe they've been referred to you with medically unexplained symptoms, and it's your job to find out more about this. So what do? You find out exactly what's going on, and like any normal medical history, you find out what the presenting complaint is and what the variety of symptoms are. Then you find out, well, what's brought this on? Is there anything obvious that could have precipitated the development of these symptoms? Then, in addition, and you do this normally in a psychiatric history, but not in most normal medical circumstances, you screen explicitly for depression and anxiety. And hopefully you'll see why this is important, because I alluded to it previously. They could be feeding into MUS, or MUS could be causing depression and anxiety, and this in its own right might need treatment too. Okay, So what else do you ask about? You ask about impact. So really, we should be doing this with all patients, particularly in general practice, for example. Somebody comes in and they say, you know, I've got this horrible symptom, this horrible diagnosis, be it medically unexplained or be it, you know, in the Oxford Medical Dictionary of Diseases, it doesn't matter. The point is, what we're trying to do here is get an idea of how is this symptom and set of diseases affecting this person, because then we get an idea of how bad things are and how we can help them. Then we ask about sleep. So as I've said, sleep and mood are interrelated. And then we continue on with the rest of our history. And that includes medical, psychiatric, and asking about family history. And here at the bottom of that top section, it says, ask if there are any other long-term conditions or mental health conditions in close family members, including things that occurred in the patient's childhood. So I already alluded to these things. Childhood experiences and family history are very important here. The authors carry on and can kind of continue fleshing out the history. And then the history at the bottom, you'll see specifically asking about childhood adverse events, parental ill health, and other illness in family that could be precipitating or predisposing the development of MUS. So a couple of other points. Somebody comes into you and they've got a long list of symptoms. What do you do about it? Well, it's incredibly tempting to say, right, well, I can't deal with all of that, so you've just got to pick some for me. And in some situations, that's a valid strategy, and it's important to be pragmatic with time. But actually, with someone with MUS, it's important to list all their symptoms. And if you're not going to deal with all of it in one go, they need to feel related. Kind of therapeutic. Explaining a diagnosis of MUS and how we understand it as medical professionals, relating it to them is hugely important. These people probably have been, you know, bouncing between different specialties, and they still don't know what's going on, and they feel hopeless and frustrated, and they feel pawned off, and it's, you know, it's a really sorry state of affairs. If you take the time to say your symptoms are real, I'm sorry that you're going through this, but I need to explain to you that I can't find an alternative explanation. The test is negative, and whilst that might not reassure you, what it means is that we can stop investigating now and start understanding how and why you're experiencing the symptoms that you are, and we're going to try and, from that formulation perspective, unpick things and make you better. And when you give hope for the future and you say, I have seen people in this situation get better, and I have confidence that you can too. We just need to understand a little bit more about how and why these things are going on. So this is essentially what I've just summarized in a short paragraph verbally just on the previous slide. And here is a concept of understanding, again, the impact of symptoms and what the patient wants to work on, and developing a strategy to actually bring that about. So once you've done that, you've an explanation. Now it's time to actually do something about it. So what are you? The mainstay of treatment for MUS is psychological therapy. And in your consultation and explanation with the patient, it's hugely important to say, you know, the treatment for MUS is largely psychological, but it doesn't mean that we think you're mad. It doesn't mean that you're making things. What it means is there's a psychological influence on symptoms that's very hard for us to explain and pin down. But what we do know is that cognitive behavioral therapy, talking therapy, and psychodynamics, to understand other, you know, factors in your life to do with mood and stress and family and all of these important things, these help us understand how and why you're experiencing symptoms. And actually, from this formulation perspective, to kind of reverse that process by understanding how someone has become in this situation. So it can be very intimidating as a clinician to say the word psychological therapies to a patient who probably has been told in the past that they're making it up, because immediately the patient is gonna going to have a problem with the word psychological because it's insinuating something that they're not comfortable with. So, you can be preemptive with that, and you can be productive and positive about it and say, actually, CBT does work for a lot of people, and if you'd be willing to try it, then let's give it a go. Depending on where you read, there's different statements about its efficacy, but I think by and large it's considered an effective treatment for many presentations of MUS. Here's another interesting one, antidepressants. So if you've got depression, again, either causing MUS or as a result of MUS, or all kind of just jumbled up somewhere in between, why would you not treat that as well? Because the patient is suffering with low mood, and if antidepressants are going to work for them, then why not try it? Now, the Royal College of Psychiatrists have also suggested that even if you haven't got depression, antidepressants might still help, although we're not quite sure on why that is. And I'm afraid I can't offer you an explanation for that. But again, it's one of those situations where you say, I want to treat with antidepressants, and they go, well, I'm not depressed. And you say, well, antidepressants work in a number of different ways, and we don't quite understand all of the ways that actually have functions. And yes, it can be for low mood and depression, but actually these still might be helpful for you. And I'm not calling you depressed, but these medications might help. So hopefully I'm impressing upon you that language is incredibly important here, because of the way that patients experience and understand language, and particularly when it feeds from negative experiences with healthcare professionals in the past, getting that right is super important. Okay, so now some more kind of specific examples of MUS. I've picked ENT here. Why have I picked ENT? Well, I like ENT, that's why. But also, it's very common for someone to present with MUS in an ENT clinic. And here are 5 or 6 examples of symptoms that someone might present with. Really important for me to say that MUS permeates all specialties. And there are slides in other people's presentations that show examples from different specialties. But here in just one, hopefully this is demonstrating that actually there's quite a few different things going on. So dizziness, tinnitus, that is a kind of ringing in the ear. Post-nasal drip, which is actually a ridiculous term, because the authors have out that actually nasal mucus is too thick to drip, so post-nasal drip isn't a thing, but this is what it's called. The idea that someone is selectively attending to normal mucus at the back of the nose, attributing a pathological meaning to it, focusing on it all the time and clearing their throat. So someone presents with hoarse voice and cough and throat clearing, they haven't got cancer, they haven't got tonsillitis, they haven't got a chest infection, they're clearing their throat all the time. And the treatment actually is to just not do that. It sounds ridiculous, but that's the advice. And actually, if you follow ice cold water, it stimulates normal swallowing and kind of breaks this urge to clear the throat until someone hopefully will not be wanting or needing to consciously, voluntarily or involuntarily clear their throat, because actually that could be doing them more harm than good. Atypical facial pain is a bit of a weird one. It's this idea that there's kind of strange facial pain sensations that kind of move about, and you can't attribute it to, for example, trigeminal neuralgia, which you might see in an ENT kind of world. Globus is the sensation of a lump in the throat. This is quite a common presentation. The authors didn't actually give a clear treatment recommendation for this, but for many of the other ones, they've spoken about CBT, antidepressants, and a psychiatric referral. Why would you do a psychiatric referral? Again, it's not because you think someone's mad, it's because you want a specialist to take a focused approach to history taking, to creative formulation, and potentially as the first step in offering CBT. Okay, chronic fatigue syndrome. Also known as ME. So what is chronic fatigue syndrome? CFS is a debilitating condition characterized by, here in this kind of diagnostic list, a variety of different symptoms: tiredness, trouble sleeping, pain in the muscle and joints, brain fog, headaches. And at the bottom, you'll see autonomic manifestations, neuroendocrine immune dysfunction. Now, hopefully that looks remarkably familiar to you when they were talking about mechanistic explanations of MUS. And here we have examples clinically of how these things might have gone awry. And further to that, there's more kind of specific, more detail here on the immune system and at HPA axis level, what might be going on from a mechanistic perspective to explain these symptoms in chronic fatigue syndrome. Now, just for a couple of seconds, I wanted to talk about this. Now, one of my lecturers in the 5th year psychiatry course at Oxford spoke about this controversy. So I thought I'd just put in an example from the Action for ME webpage, which is explaining why something called graded exercise therapy was initially on the NICE guidance for treating chronic fatigue syndrome, also known as ME, and why it was later removed. So backlash from community basically got the guidelines updated to not offer graded exercise therapy. And here on this web page, it's saying that it's because the quality of evidence was very low. However, here's a BMJ article, which is talking about opinions of doctors in this, both saying, we can't quite believe why this has happened. NICE is evidence-based. The evidence was there. The evidence showed efficacy for, here they're talking about CBT as well, and graded exercise therapy, but they've taken it out. So I'm not going to offer an opinion here. It's for you guys to form your own opinion of why there might be this controversy and the consequences and fallout of this. But I just want you to cast your minds back to about 10 or 15 minutes ago. I was talking about the example of someone with chronic fatigue who is really tired, so stops exercising and moving around, and that gives them time for this vicious cycle to kick off. So whether or not graded exercise therapy, which is the idea of gradually introducing more and more exercise and movement into someone's life, would be a good thing or not, well, the evidence says that it might be, but it's now not in the NICE guidelines. So you guys can form an opinion on whether that's controversial or not. But I think it was just interesting for me to flag here. Okay, now in the last 3 or 4 minutes or so, I'm just going to talk about the final 2 bits, which is functional neurological disorder and inflammatory bowel syndrome. And then I'll stop and I'll open the floor to questions. We're nearly there. Okay, IBS, what is it? Okay, so IBS is another kind of sub-umbrella term to describe a constellation of GI-related symptoms that might be irregular bowel movements, bloating, nausea, diarrhea, constipation, that, again, can't be explained by, for example, Crohn's disease or ulcerative colitis, but there's still something going on. And there's this idea of a kind of bidirectional interaction between psychological and abdominal factors that could be responsible for developing these symptoms. Once again, HP axis, immune system replicated in the pathogenesis. And CBT, again, is effective. So the key features that I've explained to you are now applied to a kind of disease-specific focus, and that is IBS. Okay, let's zoom in on, oh, hang on, the right slides, actually. Okay, I've got the wrong slide deck up, but I'll make sure that we send the right ones round to you. It's just one more slide that I added in, which is from a Lancet paper from 2016, which is suggesting some mechanisms that are causing IBS symptoms. And just to list them off, they're talking about central processing of stimuli from the bowel. They're talking about anxiety and depression. They're talking about IBS after a bowel, a GI infection, and inflammation. They're talking about visceral hyperalgesia, and they're talking about malabsorption of bile acid. So there's a mixture of immune, infectious, and cognitive processes that are kind of perhaps in combination even contributing to this constellation of GI symptoms that isn't explained by an alternative diagnosis. Okay, and finally, before I wrap up, functional neurological disorder. So this is the third and final kind of example of a subclump of symptoms. And FND is in the DSM-5 criteria as its own diagnosis, separate from somatic symptom disorder, for example. And it's the idea that you've got neurological symptoms that, despite investigation, no one can find an alternative neurological explanation for. So how could this present? It could be numbness, tingling, weakness. It could be having a seizure. It could be a kind of full-on fit that is non-epileptic. So what we mean by non-epileptic is that video telemetry and looking at symptoms and correlating them with an EEG has shown that it's not epilepsy, but this patient is still seizing. And we don't quite understand exactly what's going on and what could be causing this. But there's this concept that some problem with the kind of the way that the brain and the mind are connected, and perhaps it's in response to psychological trauma, for example, is actually causing this patient to have a kind of neurological constellation of symptoms that could include seizures, but they're not epilepsy, which would be the named neurological diagnosis. Third bullet point on the right-hand side. Systematic review exploring the impact of receiving a diagnosis of functional seizures, which is what I've just explained, found that approximately half of these patients had a reduction or cessation of their attacks, that is, their seizures. Although, of course, with any study, you have to look at the variability between the papers that we looked at. But this is highlighting the importance of explaining a diagnosis to someone, and that can be therapeutic in its own right. That's what I really want to impress upon you, is that the management of these patients is clear explanation, validation, and appropriate referrals for multidisciplinary full assessment of somebody's symptoms in a holistic way, with a cognitive behavioral model to understand how and why their symptoms have developed, and from that perspective, how we can Okay, cool. So this is just, as I said, a screenshot from PassMed. Lots of multiple choice questions focus on symptoms that are related and sound kind of similar, but actually are distinct. And there's this idea of hypochondriasis, somatization, conversion disorder. All of these terms are outdated now, and the new DSM-5 is talking about somatic symptom disorder and functional neurological disorder. But MCQs might not have reflected that yet. So this screenshot from the high yield textbook is essentially just showing you examples of how these things might present and the subtle differences between them. Okay, next slide. And this is just wrapping up. So MUS, a very real, find another explanation. It's an umbrella term. There's multiple different ways of describing different constellations of symptoms under this MUS category. Doctors consider it incredibly challenging to manage. There's this idea of a heart sink patient, quote unquote, heart sink patient. And really what I'm trying to convince you of is that that's an inappropriate way of considering these patients. They are suffering and they've got symptoms that need treating. And many of these people can get better with appropriate support. And how do we do that? Well, we understand how and why they've developed these symptoms. We validate them, we explain the diagnosis of MUS and what that means, and we offer CBT. Okay, next slide. This is just a screenshot of the Oxford exam essay questions that were set on MUS from 2018 and 19. But basically saying if you reproduce the lectures from the psychology course, you'll pass. But actually the stronger answers are incorporating this biopsychosocial perspective, adding some reflections on the topic and insight into the challenges of clinical practice with additional self-directed reading. Hopefully this lecture gives you examples of self-directed reading that I've done that you can leapfrog, an insight into the challenge of clinical practice, and I've shown you exactly how the biopsychosocial model feeds into this. So that's it from me. The very last slide on this shows the references that I used to create this. So feel free, if you don't understand something, to follow it up on the reference, or just use it for your own further reading. And I'd happily take any questions and help how I can. And there's also the QR code to scan as well for feedback. But if anyone has any questions, feel free to pop your camera on or just unmute.